Hello, my name is Jeff Bryan, and I'm a clinical pharmacist with the Leukemia Service at MD Anderson Cancer Center. I want to thank you for joining this presentation about a multidisciplinary care approach to managing patients with polycythemia vera and essential thrombocythemia, which I'll refer to as PV and ET. Treatment of cancer, in our case, myeloproliferative neoplasms, requires that healthcare providers and caregivers from many different disciplines work together to address the physical, psychological, social, and spiritual needs of the patient. This model of multidisciplinary care encompasses three teams, Team A, B, and C, working in concert with each other. For example, members from different disciplines with specialized skills and expertise coordinate and communicate a patient's treatment plan, address the patient's physical and psychosocial needs, and ensures the implementation of best practice evidence-based care. This particular model describes the roles of the active caregivers, such as a hematologist who specializes in myeloproliferative neoplasms, oncology nurses, advanced practice providers, and oncology pharmacists. Caregivers providing base support may include psychologists or chaplains, and community support may include advocacy groups or hospital administrative staff, all striving to provide a full continuum of cancer treatment experience. Teams practicing in this way should understand the function and importance of each member's role, increase patient involvement and satisfaction with treatment, and ultimately improve patient outcomes. In some cases, the function of some of the members may overlap. Multidisciplinary care models for cancer patients are in practice in many countries, for instance in the United States at MD Anderson Cancer Center and throughout Europe and Australia. The value of a multidisciplinary team approach has been well documented across a wide range of clinical settings, including management of diabetes and chronic lung disease, prevention of cardiac vascular disease, as well as the management of patients with breast cancer, colorectal cancer, palliative care, and heart failure. The evidence suggests that multidisciplinary care can reduce mortality, improve quality of life, and patient satisfaction. Despite the strong evidence to support positive outcomes of a multidisciplinary healthcare approach, several barriers to its wider acceptance do exist. For example, this care model may be a change to a practice that is sometimes resisted by clinicians. As with any program, a lack of funding to support this care model may exist, as well as time for clinicians to collaborate or attend multidisciplinary care meetings. Although challenging for some clinicians to lead a multidisciplinary team, it is my opinion that an experienced hematologist and care team in myeloproliferative neoplasms should be involved in the management of these patients due to the complexity associated with its diagnosis and disease-related complications. ET and PV are characterized by thrombocythemia and erythrocytosis, respectively, and can be complicated. Although many patients with ET are asymptomatic, when symptoms are present, complications may be related to small vessel disturbances such as headache, visual disturbances, dizziness, coldness of the fingers or toes, burning, redness and pain in the hands and feet. It is also well known that patients with ET are at increased risk for thrombotic complications such as stroke, transient ischemic attacks, deep vein thrombosis, pulmonary embolisms, or even heart attacks. Similarly, patients with PV may harbor a wide range of symptoms such as fatigue, headache, sweating, blurred vision, dizziness, feeling of early satiety due to splenomegaly, itching, especially after taking a shower. In this setting, it is important for team members to be familiar with these complications and the risks associated with developing thrombotic complications. Although none of the current treatment options available have been shown to delay or prevent the evolution of ET or PV to more advanced diseases such as myelofibrosis or acute myeloid leukemia, many people who suffer from PV or ET can enjoy longevity with proper monitoring and treatment. Therefore, it is especially important for healthcare providers to support and reinforce a healthy lifestyle for all patients to decrease or prevent cardiovascular complications. Given the potential complexity of these hematologic malignancies, these patients can benefit from a multidisciplinary care approach, which should include a hematologist and a hematopathologist familiar with PV and ET, an oncology clinical nurse, an advanced practice provider such as a nurse practitioner or physician assistant, and an oncology-trained pharmacist. These core team members will often have overlapping responsibilities. For instance, the physician and the advanced practice providers are both capable of doing a full assessment, including a history and physical, while the pharmacist assists the team with monitoring for disease-related complications, response to treatment, drug-related side effects, and encourage the patient to be compliant with the treatment plan. In this setting, a clinical oncology pharmacist is also readily available to assist with ensuring appropriate uses and dosages of medications and address clinically significant drug interactions. The oncology clinical nurse is the patient's care planner and the driver of the patient's overall care and helps coordinate the various members of the healthcare team. As noted earlier, thrombotic complications are common in PV and ET and should be treated as in any other patient with appropriate doses and intensity of anticoagulation. Therefore, vigilant monitoring by a cardiologist and the primary oncology team is often required. Given the many issues associated with myeloproliferative neoplasms, it is important for patients to fully understand the spectrum of their disease. Having said this, a recent report from the MPN Landmark Survey conducted by Dr. Mesa and colleagues, which was the first large U.S.-based survey designed to evaluate disease burden in patient-physician communication in the myeloproliferative neoplasm setting, revealed that more than one-third of the patients with myeloproliferative neoplasms were not very satisfied with their physician's overall management and communication. In addition, other discrepancies between patient and physician recollection of interactions revealed a need for improvement in patient education and patient-physician communication. And according to Dr. Mesa and colleagues, patient and physician respondents often view the assessment of MPN prognosis, disease burden, and treatment goals differently, with physician respondents overestimating the ability of patients to recognize symptoms as myeloproliferative neoplasm related. Looking more closely at the results of the survey, the MPN Landmark Survey showed that the majority of physicians treating PV and ET reported using prognostic risk classifications with their patients, whereas a smaller percentage of patients remembered their physician providing a prognostic assessment. In addition, differences were noted between patient perception of physician's management and the practices reported by physician respondents. Compared to the patient's perception, a larger proportion of physicians recalled asking patients about their most important PV and ET-related symptoms during a symptom assessment and referring to a full list of symptoms when discussing potential symptoms and disease progression. The perception of the patient and the physician respondents about treatment needs and goals were also generally not well aligned. The most important treatment goals for the patient in the PV setting was slow or delayed progression of the condition, whereas prevention of vascular or thrombotic events was most important for the physician. However, in the ET group, many patient and physician respondents agreed that prevention of vascular or thrombotic events was the most important treatment goal. However, there remain notable differences about the other treatment goals in the ET setting. Given these gaps in communication between the patient and physician respondents revealed by the survey, there seems to be a need for better patient education and communication between the patient and the physician, which may be improved with a multidisciplinary approach. In summary, some of the potential benefits of a multidisciplinary care approach for patients with ET and PV include improved patient care through the development of an agreed treatment plan among providers, provisions for best practices through the adoption of evidence-based guidelines, improved patient satisfaction with treatment and communication, and streamlined treatment pathways. With the overlap of responsibilities among healthcare providers, team members provide checks and balances to ensure that services are not unnecessarily duplicated and that everyone understands the care plan. Now, I'd like to thank you for joining this presentation.